This will be my presentation. First of all, I would like to thank Dr. Sacco, who is a very old friend of mine, and especially a proven collaboration, documented by everything that was been our work. So, apheresis techniques often have a depletion purpose, but for a few years now, many of these apheresis techniques have focused on modulating the immune response in organ transplants, in bone marrow transplants. One of these cases, which is the subject of this meeting today, specifically modulating the immune response in a condition characterized by a marked inflammatory reaction. Immunomodulation is a therapeutic approach to disease which regulates the immune system's response using these mechanisms and trying to regulate them in such a way that these mechanisms can be used to keep the inflammatory process under control. Immunosuppression is something completely different. Through pharmacological therapies, above all, it aims at blocking certain inflammatory processes that support therapy. Obviously, immunomodulation often has low impact on the patients, has reduced clinical complications, and above all, as we see with photopheresis in organ transplants, it preserves strong immunocompetence skills. Monosuppressive drugs, on the other hand, while having proven efficacy, have a set of side effects which we have to take into account, and they often reduce immunocompetence, so there are actual complications. This first work of 2015 already highlighted, when evaluating reaction mechanisms in ulcerative colitis and Crohn's disease, how there was an altered response and an altered interaction between the endoluminal environment of the gut and the vascular environment of the immune system. So, from this, it was already possible in 2005 to infer that interventions to regulate the systems that determined all the inflammation that support these clinical pictures would probably have achieved the therapeutic goal. In this diagram, we see that if the activity of dendritic cells is followed by a response that is inadequate, altered for various reasons, instead of having anti-inflammatory control, a normal control over the response, there is an expansion in an inflammatory direction, and hence the mechanisms that support the inflammation which characterizes both ulcerative colitis and Crohn's disease, with some differences that we will analyze a little later. Anyway, the focal point of the response, as in the whole immune system, is the dendritic cell, and how it interacts with the endoluminal environment, and how, as in recent years we have identified, it interacts with the microbiota, and how the dendritic cell initiates the immune response. Therefore, in both diseases, which are the subject of this meeting, the altered inflammatory response is a reason for inflammation. So we must aim our weapons, and Aducolum is one of these, to try to reduce the altered regulation and to restore normal conditions in the immune response. Which are the factors that can affect it the most? There are many. Surely there are genetic aspects and aspects related to diet, smoking, hygiene, to stress. There may be many elements that trigger something that alters immune response, as we will discuss later. In ulcerative colitis, starting from dendritic cells, a cascade is triggered, a cellular activation, a cascade of cytokines and progressive activation of cells that bring this element, which we need to focus on, because it also helps understand how adecolum works, that increases leukocyte recruitment in the vascular part of the intestinal wall. Then, starting from the microbiota, the altered response, the altered interaction with the dendritic cell, and from here all of the cascade, naive T cells and all of them, the cytokine cascade and cellular activation, lead to increased recruitment, increased recall of leukocytes, and we will see how they can be affected by adecolum, trying to better regulate this response. Conversely, in Crohn's disease, more than the consequence of what happens in the relationship between the microbiota dendritic cells and consequent response, more than having greater recruitment of leukocytes, there is a recall of T cells, thus greater commitment of T lymphocytes, and a cytokine cascade, grossly overlapping that of ulcerative colitis. So we can say that dendritic cells are the starting point in the altered response. But it is especially the presence of receptors, such as receptors specific for the Fc fragment of immunoglobulins, become the indispensable element, the element on which adecolum works. Because the recall, the absorption of cells via cellulose acetate beads, has the Fc fragment of immunoglobulins as the focal element. As we see in this figure, the absorption of neutrophils and macrophages occurs through the Fc fragment. Sorry, I am hurrying a bit. Time is running out. Granulocyte and monocyte apheresis, by inhibiting the migration of leukocytes, activated by immunomodulation, capable over time, and on this regard, the most recent works, Dr. Bianco will then highlight them, aim to intensive treatments, as already in the work conducted with Dr. Sacco in the past years, we assumed. That is, the possibility to extend treatment on adecolum to granulocyte and monocyte apheresis to longer times and higher frequencies, precisely to have the possibility to completely modify the cellular pattern and therefore the cytokine pattern that supports the mechanism of action of these inflammatory diseases. Therefore, the objective of granulocyte and monocyte apheresis is to modulate the inflammatory response, capturing, absorbing, and gradually reducing all activated cells in such a way that the pro-inflammatory response of the immune response is reduced and the anti-inflammatory pathway prevails. Various studies have been carried out. We did them, but as I mentioned, and how we'll see in the next report, the efficacy of granulocyte and monocyte apheresis, according to these authors, other authors as well, it is a somewhat widespread opinion, it must have time to induce what I tried to describe quickly in these minutes in such a way to be able to deactivate the inflammatory pathway and induce the expansion of the anti-inflammatory response. It would be desirable, in the work that we did in Pisa, we attempted to identify predictive factors. At the moment that I know about, but also based on the literature I reviewed, decisive elements do not emerge in this sense. But if we found an element that allows us to monitor the therapy with granulocyte and monocyte apheresis, we could probably calibrate the apheresis therapy much better and have more effective responses. Thank you for your attention.